Thank you, Dr. Lombe and the organizers for the opportunity to discuss two abstracts presented at ASCO 2020 on new applications for immune checkpoint inhibitors in urothelial bladder cancer. As an introduction, I would like to highlight a few pertinent points on the epidemiology and treatment of bladder cancer in the African context as it relates to immunotherapy. In a recent review by Adeloye et al., a steady increase in the estimated incidence of bladder cancer over the past few decades in Africa was noted. Reference was also made to the shift from predominantly squamous histology associated with schistosomiasis in Northern Africa to urothelial cancer associated with increased smoking and urbanization. When considering standard of care treatment, we know that there is limited and variable access to surgery, radiotherapy, chemotherapy, and novel therapeutics across the continent. Despite bladder cancer not being an AIDS-defining cancer, people living with HIV are living longer and are becoming at risk of developing bladder cancer. Immunotherapy trials have, however, thus far excluded HIV-positive patients based on the risk of toxicity. And finally, the prohibitive cost of immunotherapy and the lags in regulatory approval and commercial availability makes it unavailable to the average sub-Saharan African patient. Starting in 2016, a number of immune checkpoint inhibitors have been approved for the management of metastatic bladder cancer as second-line treatment in the post-platinum setting and as first-line treatment for platinum-ineligible patients. In the post-platinum setting, pembrolizumab has shown an overall survival benefit in a phase 3 trial, with other ICIs showing overall survival benefits in the phase 2 setting. Notably, a phase 3 trial of atezolizumab has shown progression-free but not overall survival benefit. In the metastatic first-line setting, chemotherapy with cisplatin gemcitabine or Dosden's MVAC is still the gold standard with high response rates and durable survival in some patients. But we also know that many patients with advanced bladder cancer have one or more contraindications for cisplatin chemotherapy. Substituting carboplatin for cisplatin has not resulted in equivalent response rates. It's in this setting where ICIs have come to the fore as an effective alternative or adjunct to standard palliative chemotherapy. For platinum or chemotherapy ineligible patients, promising and sometimes durable responses have been shown in phase 2 studies for first-line pembrolizumab in KEYNOTE-052 and for atezolizumab in IMvigor210. Because of the proven benefit with ICIs when patients relapse after platinum-based chemotherapy, the question arose whether moving the ICI to an earlier point in the treatment by using it as maintenance therapy after a successful course of platinum-based chemotherapy would augment this benefit. This hypothesis was tested in the phase 3 Javelin 100 study of avelumab maintenance treatment post-palliative chemotherapy. The results of this study, which I will present to you shortly, represent the first bladder cancer study to ever be presented at an ASCO plenary session. In the muscle-invasive curative setting, no data exists to support the use of ICIs yet. There are currently multiple ongoing trials investigating the role of ICIs in the neoadjuvant setting. Adjuvant atezolizumab was compared with best supportive care after radical cystectomy in the IMvigor010 study, and we will look at the preliminary results of this study as well. And just to complete the picture, for non-muscle invasive urothelial cancer, the role of ICIs have been explored with pembrolizumab showing the most promise. In the Javelin 100 study, 700 advanced urothelial cancer patients with a response or stable disease after at least 4 cycles of platinum gemcitabine palliative chemotherapy were randomized to switch to maintenance avelumab until progression, toxicity or withdrawal, or no avelumab. Both groups received best supportive care. The avelumab was given as a 3-weekly infusion of 10 milligrams per kg. The primary endpoint was overall survival from randomization, and no crossover was allowed within the study. If we look at the Javelin 100 patient characteristics, we see that the 2 arms were well balanced in terms of primary and metastatic sites, PD-L1 status, and prior chemotherapy type and response status. Notably, PD-L1 positivity rate was higher than in most other urothelial trials. In a planned interim analysis after 324 events, the primary endpoint was resoundingly positive, with a median overall survival of 21.4 months in the avelumab maintenance arm versus 14.3 months in the best supportive care arm, and a hazard ratio for death of 0.69. This is the longest overall survival ever documented in a phase 3 metastatic urothelial cancer trial. And we see that this survival benefit holds true when we separate out the approximately half of patients who were PD-L1 positive. Notably, PD-L1 positive patients in both arms did better than their PD-L1 negative counterparts. The safety profile of avelumab was found to be manageable and consistent with previous studies of avelumab monotherapy. TEAEs led to discontinuation of avelumab in only 11.9% of cases. No grade 4 or 5 immune-related AEs occurred, and hypothyroidism was the only AE occurring in more than 10% of patients. The discussant of this plenary abstract, Dr. Elizabeth Plimak, compared the Javelin 100 results to that of a phase 2 HERNGU14 1-8 study, in which pembrolizumab maintenance therapy was compared to placebo in the same clinical setting. We see a consistent benefit in progression-free survival, supporting the approach of switching to a checkpoint inhibitor in the setting of response or stable disease after platinum chemotherapy, as opposed to waiting for progression, the approach used in the studies that established ICIs as an effective second-line treatment option. But in contrast to Javelin 100, this study did not show a difference in overall survival. Pimlak attributes this to the possibility that access to subsequent or crossover ICI therapy might have been higher in the phase 2 study and could have obscured the survival benefit effected by the maintenance strategy. Cross-comparisons of overall survival in the Javelin cohorts and, for example, the phase 3 Keynote 045 study of second-line pembrolizumab would suggest that offering maintenance ICI therapy affects a larger benefit in overall survival. But we must remember that Javelin 100 excluded patients with progressive disease within 14 weeks of palliative chemotherapy, whereas most of the second-line trials included these platinum refractory patients who are likely to have a worse prognosis. Additionally, the time points from which survival is being calculated are essentially different in the 2 scenarios. Does this mean that switch maintenance checkpoint inhibition should now be accepted as a new first-line standard of care for advanced urothelial cancer, as opposed to only instituting ICI therapy at time of progression, an approach now being called the treatment break approach, because it affords patients a window of time free of treatment side effects? With its unprecedented overall survival benefit and manageable side effect profile, the Javelin 100 authors certainly think so, and others agree, as evidenced by the fact that this treatment option has already been incorporated into the NCCN guidelines for bladder cancer. Ultimately, only a comparative study using the maintenance versus the so-called treatment break approach would be able to answer this question. In the interim, one might argue that the cost of ICIs prohibits its use as a maintenance therapy for all responders in the African setting, and that it might be more prudent to reserve it for when patients do progress. But on the other hand, if you do not have a reliable system for identifying recurrence early, you might be condemning the large proportion of patients who will progress after palliative chemotherapy to a worse and often highly symptomatic outcome. In the second abstract, Maha Hussein reported on the preliminary results of IMvigor010, a phase 3 trial that enrolled patients with high-risk muscle-invasive urothelial cancer after undergoing cystectomy, and randomized them to a year of adjuvant atezolizumab therapy versus standard observation. High-risk disease was signified by having YPT2 to T4A or node-positive disease in patients who received neoadjuvant chemotherapy, or patients with T3 or 4 or node-positive disease who did not receive neoadjuvant chemotherapy, but who were also ineligible for or who declined cisplatin-based adjuvant chemotherapy. Initially, patients had to be PD-L1 positive, but after the first 119 enrollments, all comers were allowed. Disappointingly, the primary endpoint of disease-free survival in the intent-to-treat population was negative. There was no difference between the two arms, with median disease-free survival in the atezolizumab arm of 19.4 months and 16.6 months in the observation arm. Even when subgroup analysis of PD-L1 positive patients by level of expression was done, there was no benefit of atezolizumab over observation, and this remained true for all clinical subgroups based on nodal status, site in the urinary tract, or prior chemotherapy. Overall, there is currently no role for adjuvant atezolizumab in muscle-invasive urothelial cancer. So why is there a benefit in the metastatic and perhaps even in the non-muscle invasive setting, but not in the adjuvant setting? Might it be that gross tumor is required in order to potentiate an immune response? Would a different ICI or class of ICI have had a positive outcome? These are all questions posed by Professor Heng, the discussant of the abstract. Despite its negative outcome, this trial and others like it are important in the struggle to improve outcomes for patients with bladder cancer, and it is hoped that future studies might identify effective adjuvant strategies or identify high-risk pathological subsets, like for instance T4 cases, who will benefit from adjuvant ICI therapy. I would like to thank you for your attention.